So we are, of course, as a reminder, recording this so we can add it to our website later on for those that want to rewatch or watch it for the first time. So we should be good with that. Welcome everyone to our Lakeside chat tonight. Hi, Carol, saw you hop on. Tonight is an interesting conversation. We're faced with a lot of tough decisions as we age. And one that we see quite often is how to proceed when we need someone to provide care to us or a loved one. And nursing home care is often the first idea that we might think of as what we have to do. But there are other options. And one of those could be someone coming into our home to help us. So within that vein, Kari Charette, the Director of Patient Services at HCR, is here to help us today by discussing some of the options available for those facing this now or in the future, hopefully a long time in the future, and answer some questions for us and to just give us some background on what's been happening for the industry with COVID, because that must have made their lives extremely hard. And just as a quick disclosure reminder, Kari Charette and HCR Home Care CHHA are not affiliated or endorsed by Clue Wealth Management or LPL Financial, so that those that are watching this are happy that we did our job. So Kari, I will give it away to you now, and we do really appreciate you being here to do this for us and to talk to our clients. And we're looking forward to the information that you're going to provide us.
Great. Thanks so much, Christina, for inviting me on to speak to something I'm so passionate about. As Christina said, my name's Kari Charette. I am the Director of Patient Services here at HCR Home Care. My presentation is branded because it's something that we present out to a lot of people, but a lot of this information is applicable to any home care company that may be in someone's area. It is the only home care company here in Clinton County, but there are other counties surrounding us that have home care companies as well. So my background really quick, I have been in nursing for 25 years, originally starting out at the hospital with a background in oncology and operating room, and I've been in home care for the last 20 years. The first 10 of that was at Clinton County Home Care when Clinton County decided to sell their home care agency. HCR is a company that was originally based out of Rochester, and they purchased that license from the county as they were growing, because a lot of what happens in our healthcare industry is you have to get a little bit bigger to continue to be sustainable and share your administrative costs. So I came on with HCR almost 10 years ago. It'll be April 1st, will be my 10-year anniversary. I've held many, many roles. I've been in the field. So I've been in the homes, which I still love to do with some of my staff nurses, go out and see patients in the home and help do some instruction and guidance with them. So it's always a great break when I get to leave the office and get back in touch with some of the patients again. I've had the leadership role here at HCR for greater than 7 years, and overseeing 7 of our counties that are here in the North Country, or make up our what we call our North Country region. And I'll show you quick. This is our map of where we are located across upstate New York. As I mentioned, HCR is a company that's been around since 1978. It is an employee-owned company, as well as had been started by Louise Warner, who was a woman in business, and she saw a need really for her aging father. And that's what kind of inspired her to start this company. And back in that time, being a woman, she could not get a loan from a bank and started this company with a credit card expense of $3,000 and 3 employees. And now we are over 800 employees in all of these counties. We have been recognized as the top 100 nation in our ratings, as well as 4 consecutive years as a top workplace. We've had numerous nurses and therapists that have had clinical publications in peer-reviewed journals. And we offer a full spectrum of services. So I'm pretty proud to be part of this company. I was really pleased with the transition from our county here in Clinton County, which I think is, has been a great community. I'm born and raised here. So it was a great opportunity to have HCR purchase that license at that time and be able to provide even more services than we were prior. So as I mentioned, I'm in the home care side. We do have 2 other lines of business. There are these other entities, like I said, in other areas, other counties as well. You can find a home care agency, a licensed agency, which is we refer to as a LCHA, or our care management. I will focus mostly on the home care side, which they refer to as a CHHA, or a certified home health agency. And that's where you're really getting your skilled services, such as a nurse, a therapist, and we sometimes will put in an aide to help with some bathing as that individual is getting back to their baseline. And then just real briefly, our licensed agency, that really focuses on our aid services, and that's mostly your Medicaid or your Medicaid payers like Fidelis, Nescentia, and it can also be private pay, but that's really more that personal care long-term need. And then our care management really deals with more of the social aspects. Again, most of that payment is Medicaid funded. Some of them are social workers, some of them are more of a case manager, but they're helping individuals link up with other services, and again, addressing more of the social determinants of health. And we often can have all 3 of these lines of business in at any one time for individuals, depending on what their needs are. And so just to get back to really the home care piece, this is the piece that I oversee, and these are the services in pretty much any home care you can expect to receive. Some home care agencies, as with anywhere in healthcare, do have struggles with staffing at times. So they may have some limitations, maybe with a therapy service or maybe a dietitian or something. But for the most part, you should be, regardless of what county you're living in, be able to find a home care agency that can provide these types of services in the home. So the skilled nursing part is going to be a registered nurse or a licensed practical nurse. We're going to work really closely with the patient's physician to come up with a plan of care and what that patient needs in their home. We're going to do an initial assessment. And again, it's collaborating with the patient, a patient caregiver, working on, what disease processes they have that are going on, working on what that individual's goals are. And ideally, it's meant to be a short-term intermittent service, but we certainly have people that they come in and off service all the time. So they may need something short-term initially, and maybe a few months down the road, they need help with something else, and we can certainly go back in multiple times. We also offer physical therapy. So our physical therapy is going to focus on things like the exercise programs, balancing, regaining some strength. They also will work on a treatment plan, often leaving an exercise program. They will also help to obtain things such as canes, walkers, wheelchairs. If a patient's coming out of the hospital, they often already have those prescriptions, or maybe they already have them. Our therapists will make sure that those are being used correctly in the home along with their plan of care. And a lot of times nursing will do this as well, but our therapists also really will take a look at the home environment and make sure that it's as safe as possible. They'll make suggestions on maybe moving furniture or changing the height of maybe a chair or a bed, or finding some other assistive device to help the patients be more independent in their home. They'll also look at making sure pathways are clear, make sure you have good lighting, and throw rugs are a big thing. That's something that people trip on, and pets. We all love our pets, but sometimes that can be a trip hazard too for individuals in their home. And then we have our speech therapists. So speech therapists, they can work on communications, swallowing difficulties, especially if we have someone who's had a recent stroke, helping to work with some of those cognitive pieces. Maybe they're having some issues in word finding. They also can help sometimes with medication management and making that cognitive change for that patient so they are able to better manage their own medications in the homes. And then we also have our occupational therapist. They also focus more specific on the activities of daily living. That's going to be your bathing, your grooming, those different hygiene tasks, meal prepping. So it's going to be the more fine motor skills that they're focused on, and they will work directly with a patient and the caregiver. And sometimes we'll put a home health aide in also at that time to help follow through on the exercise program for that occupational therapist. Again, trying to get the patients back to their baseline. And then, as I mentioned, home health aides. Again, this is short-term intermittent services. We put them in conjunction with what we called our skilled service, which is a nurse or a therapist. Then we can add in a home health aide to assist maybe, 2 or 3 times a week to help with that bathing and the getting dressed and maybe doing a meal prep. And then we also have a social worker. This also, like the home health aide, has to be in conjunction with a nurse or a therapist, but they can assist with some of that long-term planning and what the long-term goals are. If there is a need or a want for some long-term placement, they can also help with that. They can help with some financial pieces. We've had patients on service that really their goal is they can't drive anymore and they have a leased car and they want help to get that taken care of. Or, maybe there are some other social issues regarding groceries, obtaining their medications and being able to afford those. Is it a matter of paying for their food versus paying for their medications? If they maybe qualify for additional services through other agencies in our area, that our social workers are very in tune to what other agencies are out there, and they will also help to get those services in place. And then our registered dietitian, they will work with, patients that are having questions about their diet, especially if it's a new diagnosis and a recent diet change. They also are very conscious of cultural differences. And if, certain cultures, people eat certain things and that's something that they're used to, they may make recommendations of maybe a substitution here and there rather than a full, complete change in a diet, because we want people to be able to be realistic in what they're able to change with their food choices, but not eliminate, what they're used to from, a culture standpoint and what they've grown up with. You're going to be better to make out a substitution here and there rather than a complete radical change. And people are going to be a little bit more willing and consistent in those changes. And then some key indicators for home care. So these are not limited to, but these are just some examples of people that may qualify for home care. So if there's a new medical condition, such as urinary tract infections, a cellulitis, which is an infection pretty much anywhere on your around the skin area, a pressure ulcer, a stroke, a fracture, really any new medical condition, wounds, IVs, we can do all of that in the home. If there's a current or existing condition and it's become exacerbated, such as someone with COPD or chronic obstructive pulmonary disease, heart failure, diabetes, anyone who's had a recent hospitalization typically qualifies for home care. Medication changes, even if it's one medication change, whatever that is related to that diagnosis, we can work with a patient on that diagnosis and the meds that were changed. If there's been a decline in activities of daily living, such as the dressing, the bathing, or ability to meal prep, there's usually an underlying cause for that. So that would be something that, we would consider taking someone into home care for. Recent falls or fear of falling, the generalized weakness, unsteady gait. Again, usually a lot of those things are tied to pre-existing or maybe a new condition. And we can provide home care services for that as well. And then again, someone who's needing some new equipment, such as a walker, wheelchair, or concentrator, oxygen concentrator, that's likely going to be some new type of diagnosis or an exacerbation of an existing diagnosis. So that would be just kind of oh, okay, I, need new oxygen. So there's probably an issue with, someone's has an exacerbation of their lung disease. So these are just some ideas of if someone has this going on, that they may qualify or need home care services, but this isn't completely exclusive. There's many more reasons people could benefit from home care. And then there's a few things that are needed to qualify for home care. And these are really federal regulated. The need to be homebound. That doesn't mean that someone can't, drive to their doctor's appointments or drive to get their groceries or their medication. Sometimes there's a misunderstanding of, oh, I can never walk out the front door. What it just really is how much of a taxing effort is it for that person to leave? If they leave and they need assistance of some sort, or they're, using an assistive device like a cane or a walker, and then when they return home, are they completely wiped out and they need to rest and take a nap? That would be considered homebound. It's just that when people are leaving their home, it's for intermittent, infrequent things that they need to take care of because there is nobody else to take care of those things for them. And then they have to qualify for a skilled care, like the need for a nurse or a therapist. Again, that's going to be determined based on a diagnosis. And then the last thing that is needed is a physician that's willing to sign home care orders, because we have to operate under the guidance of a physician. We work very closely. Most of the time, it's the primary care physician. We work closely with their office to make sure that we have all the same medications that they have listed. What is really nice when you have a home care agency involved, sometimes there's multiple doctors, and we are kind of that go-between and help to get that all sorted out, because sometimes primary care physicians and maybe the cardiologist and maybe the surgeon are all not talking to each other, and patients can get really confused with their medications or what they're supposed to do. And it helps when we're able to be in there to kind of be that middle person to really help sort that all out. And then as far as billing coverage, majority of up here in the North Country of the patients that we have on service, probably 55 to 60% of our patients have Medicare, and it's a completely covered benefit under Medicare. There's no copay with it. And then we also have our patients that have Medicaid. Again, that's a completely covered benefit. And then we work with a lot of other private insurances. Most of the time it's covered. Once in a while with those private insurance companies, they might have a copay or a deductible, but we let those individuals know ahead of time what that is. And it's usually a per visit thing that there might be some sort of a copay. But we have a really robust insurance department that we have that information before we actually go out and start services, so we can make sure that we're educating the individual on that and they can make the choice. And we certainly do. Anybody who doesn't have insurance, we can do a private pay, and they can also work with our insurance team to do a sliding fee type thing if they don't have any insurance. But again, we also will refer them to other entities like care management if they don't already have a care management person on board, or Office for the Aging, to help to navigate them with them to get insurance. And then Christine, you touched on this a little bit earlier with regard to safety. We adhere to all the Department of Health and the CDC regulations and guidelines. COVID, obviously, this whole pandemic has been very challenging the last couple of years, but we've stayed on top of all of those recommendations, especially the first 6 months. I feel like the policies were changing every hour. We did definitely, like everybody else, struggled in getting personal protective equipment like masks and those kinds of things. But as I mentioned to Christine before this, we have a really good relationship with Clinton County Emergency Services, and they were able to receive some supplies such as the N95s and surgical masks from the state. And they reached out to us to make sure that we had that as well. Because we ran into supplier issues. We were searching all kinds of suppliers outside of our normal vendors to get everything in that we needed, so that when we had patients with COVID, we were able to go in the homes and take care of them. It was a whole nother challenge because we don't work in a facility, we work in patient homes. So making sure that we were putting all that equipment on, we were actually doing it sometimes in a person's driveway before going in the home. But we, followed all the precautions that were needed to keep our staff safe as well as our patients. But like I said, it was definitely a challenge, but we're not, this is something we're used to in home care. We, like I said, don't work in a facility, so we adapt very well. We're very flexible and we get pretty creative when trying to make sure our patients have what they need in their home. And so really the goal around home care is to keep people in their home and aging at home. That's where people are the most comfortable. That's where they do the best. There's a lot of studies out there that show that patients rehab and they get back to their baseline much quicker being in their home environment than they do in any type of facility. And that's where people want to be. So really that is our goal too. And like I said, this is obviously one of my favorite topics. I've been in home care for over 20 years, and having, grown up here, this is something I'm very passionate about. And it's not just a job to me. It's about taking care of our family, our community. So a lot of our staff that are caring for the patients in the home, they've had family members and loved ones that have received this service. And so we're all about, really wanting to make sure that people can live out as long as they can in their homes before going into a facility. And then we have a few testimonials. We get a lot of compliments from staff. Even today, I spoke to a patient on the phone, and she said all the nurses that have come in here are just absolutely delightful. And, she's very grateful. There are a lot of things that, people who don't work in healthcare, they don't live in that world. And so it can feel overwhelming and confusing and can cause them a lot of anxiety. And I think, being able to be in these homes or just having some conversations with them really puts our patients at ease, and that they know that they can safely stay in their home and be able to be taken care of and not have to be in a facility. Again, during this whole COVID time, the last place people wanted to be was in the hospitals because they couldn't get visitors and they had to be in there by themselves. And so they lost some of that advocacy of having that caregiver being in a facility, whether it be a hospital, a nursing home, a rehab. So as much as they could, they really held off going into the hospitals at all cost. And it's really an honor to be able to provide that service in our community to our patients. So that's really all my whole slideshow. Any questions?
Thank you, first of all. It was really good. And you can hear in your voice how much you do care about the whole topic and what you're doing. I have a whole bunch of questions, but we'll let Dolores and Carol, do either one of you have a question first?
Well, I have a personal question.
Sure.
For Mr. and Ms. Charette. Do you have any family that lives in Churubusco, or are you from Churubusco?
My grandfather and my grandmother, Morris and Della Charette. My father is Ronald Charette.
Well, I used to drive school bus for Northern Adirondack.
Oh, that's where my dad went to school.
Pick up Charettes that lived right on a corner.
Yep, on the Gagne Road.
A big family.
Yes.
And so that's your family, Charette's, not
That
your-
is.
Oh, well,
Yep.
that's nice. And I think this was a very informative and a very interesting, and you did such a good job. You must have gone to Northern Adirondack Central.
I did not. I actually went to Saranac when I was before I started school. We actually moved to Katyville, and that's where I grew up.
Well, I think you did a great job.
Well, thank you so much.
That's great. So no questions, Dolores. Carol, do you have any questions? And I should say Carol is not in the New York State area, at least if it's the Carol I think it is.
Yeah, no, I don't have any questions, but it's, and I'm not in the New York State area, but still it can be used. I'm here in Georgia, and I'm sure that the information, though it may not be with that agency, can be used, for other agencies, and hopefully I won't have to use it for quite some time.
Absolutely. Yep. So a lot of what I spoke to, it's federal. So that means that the home care agencies follow a lot of the same across the entire US. And there are home care agencies in every state in the US.
All right, I do have a couple questions then.
Absolutely.
So with Medicare, they often say that there's no coverage for in-home care, but yet when towards the end of your presentation, it mentioned that Medicare does cover these costs. So I guess I'm confused on the difference in, the information that's being provided from Medicare saying that they don't provide home health care.
So we do, that is our major payer is Medicare. We're not in there for hours at a time. If that's maybe what Medicare is referencing, maybe they're talking about blocks of nursing hours, which is more of a private duty. Our visits are short-term intermittent. So when we go in to do that initial visit, we might be there 1 or 2 hours to get all that intake information. And we're doing a full head to toe assessment. And then, we may come back a couple of times the following week. Again, it's going to be very specific to what that person's needs are. So for example, if we're doing wound care, we usually try and get the patient and a caregiver engaged in that, because the more that they're engaged in it, they're really going to follow through with it. It's more convenient for them to do it on their time frame, but we're in there always providing the education and always checking on that wound and how is that wound doing. It may be in an area where a patient can't reach and they might not have a caregiver. So we might be the only ones in there doing that. But those visits are, going to be focused around providing that wound care and checking on that patient. We won't be staying there for hours at a time. It'll be for that period of time that we're doing that assessment, checking the vital signs. We certainly, can be called at any time. We do have on call. So we always have someone available to answer the phone and answer questions. And if it's a visit that needs to maybe be moved up early for the next day, we can do that to check. Maybe it is, like I said, the wound. Maybe it's someone who, just came home because they had an exacerbation of their congestive heart failure. And that's what we're going in, is focusing on, listening to their heart, their lungs, and talking to them about what the signs and symptoms are. If they start to kind of head the other way, or is their weight getting elevated? Those are the things that are the skilled interventions that we're doing. And those visits typically are about 40 minutes long. They might be a little longer. They might be slightly shorter. Again, it's going to be very specific to what that patient's needs are. But so I don't know if that's maybe what Medicare is referencing, is more of a private duty, having someone there for 4 hours or 8 hours every day. That's not the type of services that we provide. But we, whenever possible, we will have therapy go in if the patient qualifies for that. And we work with our other disciplines. Our goal is really to get the patient back to a baseline or better than what they were prior to receiving our services, so that they can continue to function independently in their home with the education and the interventions that we provide.
And I think that really what it is, when Medicare is talking about it, they're referring to long-term care, which is not what you're trying to do. You're doing short care.
Correct.
Right. And so I think that that would be the major difference. But there, you can understand why people would get confused.
Oh, sure.
You know, hey, I know somebody that Medicare is paying for somebody to go into their house. And so, along those lines, is it a 9 to 5 type of job? Or do some of your nurses have to go in at night to people's houses? How does that work?
For the most part, most of our staff work during the daytime. Again, our office is, 8:30 to 5-ish, but our staff really flex their time around the patient needs. They might have a patient that needs to be seen earlier because maybe that particular treatment has to happen at a little earlier. So they may finish their day a little earlier, but for the most part, they're working that Monday through Friday daytime. But when we get someone new in service, say they have, some sort of an IV that we may be hooking up for the first time, and it's a little bit later in the day, maybe it's even 5, 6 o'clock, we will accommodate that, but we usually work with the hospital on that. Again, we are looking for a caregiver to be involved because it's not something we're going to go in every single day to do that. So before they discharge a patient with that, we work very closely with the hospitals to make sure that there is someone, either the patient can learn or they can learn, because we're really more that support service that they can call us and say, I can't get this IV to work tonight for whatever reason. And we will either help talk them through that or go out and make that extra visit. But it is for the most part Monday through Friday. We do have some weekend coverage as well, but there's always someone to answer calls 24/7.
Okay. And it sounds like the process starts by a doctor or an emergency room visit or something where.
Yep, it can be any of, we get referrals. Most of our referrals come from the hospitals. We get them from nursing homes, rehabs, as well as we call them community referrals. They come right from the doctors themselves. But a lot of times, even if they're coming from a nursing home, a rehab, a hospital, it's really going to be, I would say maybe 80% of the time, that primary care physician is going to be the one that's still overseeing the care for that patient. They're going to be the one we contact if there's changes with the medication or a treatment, or if we have a concern and we want to make them aware and see, how they want us to proceed. But we can get referrals. We can get referrals from anyone. It just, we still ultimately at the end have to have a doctor that's willing to sign the orders. So we can, we've had neighbors or daughters or, other caregivers call and say, hey, I really think I need this service. And so we help direct them how to get that referral information to us. That, oh, you're going to the doctors today, let them know that you want home care services. They'll send the referral over and, we'll take a look at the information that they send and we'll work to try and get them qualified for it.
Okay. One related question, one unrelated question. So we'll go with the related first. Have you had any staffing issues getting nurses?
We've actually been very fortunate with our nursing staff, even with everything with COVID, with the mandates, all of that. We've been very fortunate. We've been fully staffed with nursing. We've had therapy. That is the one area in the North Country that sometimes we have trouble recruiting therapists in the area. But as of right now, we're staffed really well. And I know and this is all across upstate New York, I know that home health aides are hard to find. We could always use more home health aides. So we've been doing we call them core classes. Essentially, it's anybody off the street, we can bring them in, and we've run a couple of those classes where I think it's 13 days. Our licensed agency does it, and they train them completely to be able to function as a home health aide in the home. So we've tried to be very creative in recruiting or creating employees in that way. But that's been something that's been across this entire upstate New York, is struggling to find that level of caregiver, the home health aides.
Makes sense. All right. And then the unrelated question, which you may have no idea about, so I'm putting you on the spot, is, are there people that can go into a person's home and give suggestions on how to maybe make it a safer place for them to be able to age in place?
So anytime that there's a home care entity in there. Our physical therapists and occupational therapists can make those suggestions.
I was thinking prior to that, before it gets to that stage where somebody,
where they need something.
yeah.
There's another agency called SAIL. They do that Southern Adirondack Independent Living. They have an office located here on the US Oval. And I believe they're able to maybe do some of that. I know that they're able to do some home modifications. I don't want to speak too much to their program, but I think there's quite a bit of things that they offer through that program. So that may be a possibility.
Perfect. I am monopolizing Kari's time. Does anybody else have any questions? No? All right. Well, thank you very much, Kari. As Dolores said, it was extremely informative and just so helpful for us to know this and to be able to clear up some, maybe some things that we thought worked one way and work another way instead. So misconceptions about this, but it was a great presentation.
Yeah, thanks so much for having me. And if there's any other follow-up questions, don't hesitate, reach out. I can answer them. And
yeah, and we might have some, when people view this on the website, that, people might want to reach out to you. So we'll make sure to have your contact information.
Absolutely.
All right, appreciate it.
All right, thanks
Thank you
so
very
much.
much, Kari.
Yeah,
Thank
have a great
you.
night.
Bye, ladies.
Very good.